Hello, my dear friends. I'm Dr. Vaishali Bharambe. I've been teaching anatomy for more than 25 years and I love it. This lecture is a part of my surgical anatomy series where I explain the anatomy, the development, the histology you should know to be able to perform a particular type of surgery. So it's a surgical anatomy series. So who is going to benefit from this? Students who are doing first MBBS, students who are doing third MBBS, studying surgery, obs and gynae and so on. Even postgraduate students who are exploring or studying surgery, ENT, ophthalm, obs and gynae, they can benefit. And of course, a specialist in the field of any of these surgical branches. If you like this lecture, remember, the notes of this lecture are available on my website, vbanatomy.com. So if you, of course, are free to look at the video all over again, but in case you feel like seeing the written word, then go on the website and you'll find the notes there in the form of handouts. In either case, the bottom line is, I hope you learn. If you like this lecture, do like and subscribe to my channel. It will encourage me to make more of these informative lectures. So let's begin with a question. If you find that the patient is having a cancer in one breast, why do you go examine the opposite side as well for lymph nodes? Why is there a necessity for bilateral examination for a cancer breast of one side? With this question, let's begin our discussion about what is mammary gland. Mammary gland, it's a gland that makes us mammals. It's not something specific to you and me. Any animal that is able to nourish its young through specialized glands that secrete milk is a mammal. The elephant is here because it's a mammal. I could put all animals here because by now I'm sure you know I love them. I find them the most beautiful part of living on earth. So, introduction to human mammary gland. Mammary gland consists of breast tissue, areola and the nipple, surrounded by, of course, the supporting connective tissue. It's quite similar in males and females, yet obviously you know it's different. Let's just understand the gland first, okay? The mammary gland is a compound tubuloalveolar gland. You can see that it has a ductal system here, which is branching, and you can see that a part of the tube as well as the acini is appearing to be secretory. See, it's orange in color. That indicates that these are secretory elements. So, compound tubulo-alveolar. Tubular portion is secreting, so is the alveolar portion secreting. So, the parenchyma is made up of these ducts and the glandular tissue. Gland being supported by breast stroma. What is stroma made up of? It's made up of connective tissue, elastic tissue, adipocytes, smooth muscle, blood vessels, nerves, everything that is required to support the parenchyma. Okay? Let's develop this mammary gland now. So what happens in the 5th or 6th week of intrauterine life, a series of mammary glands begin to develop in the form of a mammary line that extending from the axilla to the groin region. With time, all these lines disappear and what remains behind is a mammary crest, specifically in the region of the pectoral or the thoracic region of that person. Now, question before we go any further was recently asked to me, what decides the number of breasts a mammal can have? Like we humans have a pair of breasts, whereas some animals have many more. So the nature is so perfect. The number of breasts provided depends upon the number of progeny in a litter. If in a litter you are giving birth to 4 to 5 progeny, then you will have 4 to 5 pairs of breasts. Since the humans give rise to mostly one infant, so we have one pair of breasts. Okay, I love the logic of it. I felt like sharing it. Okay. So now what happens? We saw that there was formation of a mammary crest. So the point where the crest is developed consists of an ectoderm on the outside and a mesoderm below. The ectoderm soon begins to depress downwards in the form of these epithelial cords with clusters of cells at the end. Soon they develop canalization Okay, but still the surface is quite flat. Just before birth, the underlying mesoderm pushes up, resulting in development of a nipple. Thus, there is formation of this basic mammary gland consisting of parenchyma, ectodermal, and the stroma, which is the underlying mesoderm. Again, which is milk? See, because the infant is in the embryo is intrauterine, it is under the influence of maternal hormones which are crossing over. So, under the influence of these hormones, breast nodules develop in the infant's mammary glands, and these can secrete a certain amount of fat-free fluid, which can be referred to as witch's milk. Okay, once the baby is delivered, and the baby within 3 to 4 weeks, this will stop. It happens in some infants. So we know that there are a lot of congenital anomalies like amastia, absence of mammary gland, polythelia, multiple nipples, and so on. But remember, inverted nipple is something that can be a sign of cancer breast and should be watched out for. I have a small question for my viewers. Do you remember a famous novel in which one of the primary characters had only one nipple? And this fact that the character had only one nipple was an important part of the narrative. Okay, so those of you who are interested in reading novels, do read a fantastic novel called Cain and Abel. Okay, you will enjoy it. You will understand that I love the fact that life is not, medicine is not one separate thing. Okay, it's life basically. So anyway, I felt like sharing this fact with you. Let's move on. So now what happens? So the male and the female are born with these rudimentary breasts. Okay, so this breast tissue is just branching ducts, and this is limited to the edge of the areola. Okay. Beyond this, in the male, there is not going to be a development of the breast unless the male suffers from gynecomastia, as seen in Klinefelter syndrome or as seen in impaired liver function. But what happens to the female when she hits puberty? When she hits puberty, the ducts begin to elongate downwards. There is a lot of deposition of fat. Okay, you can see the branching. Okay, and a solid collection of cells appears at the distal end of these branches. So now something that looks like a proper breast begins to form. Is this a developed breast? Not at all. This is an incompletely developed breast, which development will complete only after she becomes pregnant and goes to lactation. Right. So what is the gland we've developed? We saw that it's a compound tubular alveolar gland consisting of a ductal system of parenchyma and a stroma which is supporting it. Let's learn a little bit more about this gland. Each gland is made up of lobes. Okay, so there are about 15 to 20 lobes which are supported by surrounding connective tissue. These drains via lactiferous ducts through a dilatation just below the areola called lactiferous sinus. They drain on the surface of the nipple. Each lobe is divided into lobules. This is the basic of the gland. Now what happens in the microscopically, what is going on? So just a schematic diagram for you to visualize. This is the lobe, lobules. Each lobule is made up of alveoli which drain blood into ductules. Ductules join to form intralobular ducts which drain into interlobular ducts which drain through the lactiferous duct on the surface of the nipple. The lactiferous duct just below the areola show a dilatation which is called lactiferous sinus, in which a little bit of milk can be stored. Okay, so the drainage of milk is in this manner. Okay, so because we're doing this in brief, how do we remember what happens without going into details? Let's use diagrams. Remember, in a passive mammary gland, there is more ductal tissue and potential to expand than actual expansion. So here you are seeing a lobule. Each lobule contains inactive alveoli in the form of clusters. It contains intralobular ducts and a lot of loose areolar tissue. Why that tissue? Because the alveoli are going to expand. The space is there for potential expansion. Each lobule is surrounded by interlobular connective tissue containing blood vessels, interlobular ducts, and a lot of adipose tissue. So mammary gland essentially has a lot of adipose tissue. Now, remember at this stage that the interlobular connective tissue rises up to get anchored onto the dermis. This anchoring connective tissue septa are called suspensory ligaments of Cooper. What happens in cancer breast is the cells begin to migrate along these, anchoring on to the surface of the breast, causing dimpling on the surface. So these dimples indicate clear indication of underlying pathology. Now the woman becomes pregnant. What changes will you see? So what will happen is that the branching will happen some more. The alveoli will increase in number. They will develop a lumen in them. Can you see that? The alveoli have increased, the size of the mammary gland has increased, and the alveoli have developed lumen in them. In the bargain, each lobule expands a little and becomes more packed up with alveoli image. So here's a clearly enlarged lobule, enlarged lobule, enlarged lobule. You can see alveoli increased in number. You can see that alveoli have lumen in it. At whose expense did they expand? They expanded at the expense of the loose areolar tissue. Remember, we had kept that there for expansion. And the intralobular connective tissue is reduced, and there's an increase in the amount of adipose tissue. So towards the later part of pregnancy, this lumen begins to contain certain amount of milk in it. So the alveoli now are expanded, but inside the lumen of the alveoli, you can see milk. So because there is milk which contains fat as well as protein, you will see such vacuolated appearance. So now, here's the lactating mammary gland, where you can see alveoli, well-defined lobule, alveoli closely packed together, distended with milk, and reduced intralobular connective tissue some more, and a good increase in the amount of adipose tissue. So this was passive, this is pregnant, and this is lactating. You can see how the lobules just get packed up with the dilated alveoli. So now this portion of a mammary gland that has capacity to secrete milk is called as a terminal ductal lobular unit. In an active mammary gland, it consists of the alveoli draining into intralobular collecting duct and the surrounding stroma. Together is referred to as a TDLU. So what happens after lactation? For those, all the distended ends and the clusters of cells slowly begin to get absorbed, and the breast goes back to its pre-pregnancy stage, almost, not exactly. And after menopause, the cells degenerate, the branches degenerate, the surrounding connective tissue becomes, collagen fibers become reduced, elastic fibers become reduced. So a certain amount of degeneration of the gland itself occurs. Now, out of all this, what should we take forward? We should take forward the fact that cancer breast is one of the most common malignancies seen in females. So you will see that in 85% of these cases, this is a ductal carcinoma. In 15% of the cases, it is a lobular carcinoma. So where is the duct? Where is the lobule? What is normal? We must know to be able to make major decisions that this is abnormal. Right. If you're enjoying this lecture, do like and subscribe to my channel. It will help me to encourage me to make more of these informative lectures. So let's now discuss the gross anatomy of mammary gland. So mammary gland extends from the second rib to the sixth rib, lateral border of sternum to the mid-axillary line. It lies in the superficial fascia. It has no fibrous capsule. Remember, a thin layer of mammary gland, breast tissue, extends upwards beyond these given boundaries. It can even extend down till the 7th to 8th rib. And this is relevant because if you're trying to remove all the breast tissue, then you should not limit yourself to this. You have to trace as far as needed to remove all the breast tissue. The breast is divided into 4 quadrants for understanding purpose: outer, upper inner, lower inner, lower outer, and a portion of it extends away from this circular area called the axillary tail of Spence. We'll discuss about it later. The mammary gland is covered by skin, present in the superficial fascia, on the deeper side related to a space called retromammary space, which lies on deep fascia covering the pectoralis major. Deep to the pectoralis major, it's related to the chest wall, the muscles of chest wall, the ribs, intercostal spaces, and so on. What is the importance of talking about superficial fascia? Now, it's peculiar that there is epidermis and there is dermis, and then there is superficial fascia in which the mammary gland is there. So, how do you decide which is the subcutaneous tissue and where is the breast tissue beginning? So, relevance is that if you're leaving a skin flap and you're removing the mammary gland, you have to keep a flap thick enough to remain viable, but not so thick that it contains some of the very breast tissue you were trying to remove. So, that's why knowing where is subcutaneous tissue, exactly where is the breast tissue, becomes important. Some doctors have said that there's usually a clear non-breast zone between the dermis and the breast tissue. I hope you find it. The mammary bed. So this is the structures on which your mammary gland is going to rest. So it's resting on the upper 2/3 on the pectoralis major, in the lower lateral 1/3 on serratus anterior, and lower medial, it's resting on the external oblique aponeurosis. Deep to all these, of course, it's related to all the muscles of the chest as well as the ribs and intercostal spaces. The retromammary space I spoke about, is between the pectoralis major covered by deep fascia and the base of mammary gland. So this space here is called as the retromammary space. Normally the breast is able to move quite easily on the chest wall because of this retromammary space. But sometimes in cancer, this space is breached by the cancer cells anchoring the mammary gland to the chest wall, in which case you have to, the mobility of the breast reduces and you have to think why. It's also called as the Chastinax bursa. There is one more importance of retromammary space, we will come to it. First, I want to place before you something called as an inframammary fold. So what is inframammary fold? It's the point where the superficial fascia and skin of the breast becomes continuous with the superficial fascia and skin of the chest wall. The shape of this inframammary fold can be curving, straight, high, low, any. But it plays an important role in the fullness of the upper or the lower breast. Its position matters. If you're doing a surgery of mastectomy, breast lift, then this line is often used to decide the classification of the level of breast ptosis, or the level of sagging of breast. The image is self-explanatory. You can take a look at it. So this inframammary fold is important in the outcome of various breast surgeries. Let's understand how. So surgeons can alter this to enhance the fullness of upper or lower breast. It can also be an important site for placing the breast implant. So you can decide on where you want to take that incision. See here, this is an inframammary incision. So this incision, after it is healed, will not be visible. So this can be a site for incision. The other sites are periareolar, transaxillary. It is through these incisions that breast implants are inserted. It's important to remember that if you preserve the inframammary fold, it creates something like a skin envelope in which these implants can be placed for aesthetic breast enhancement surgeries. So now let's talk about where can you place implants. Since we've talked about the word implant, let's understand where are implants placed. So implants which are used for breast enhancement surgeries usually are placed in the retromammary space. You can see that here. Where else can they be kept? Yes, they can be placed behind the pectoralis major. So here's your pectoralis major. You can see the implant lying here. Let's compare to understand what is better. If you're putting it in the retromammary space, then the recovery is faster because you're not cutting any muscle. Okay, it can accommodate large implants. Problem is that if the patient's actual breast tissue is very low, then implant itself becomes visible in the form of wrinkling on the surface of the skin. The implant also hampers mammogram. Whereas if you place it behind pectoralis major by cutting and inserting it behind, then the contour, as you can see, of the breast is much smoother. It's a more natural looking breast and it does not interfere that much with mammography. However, the problem is you're cutting a functional strong muscle. There will be muscle weakness. Plus, there are some other problems. Take a look. So here you're seeing a normal, and then you are seeing how the implant has started to sag down. Okay, as it sags down, it creates an additional breast curvature, which is called as a double bubble deformity. Sometimes it sags in such a way, this is again normal, it sags in such a way that it changes the very anatomy of the breast and the nipple in this manner, which begin to look abnormally upwards. Or it can even slide upwards, okay, into the axilla, causing again the abnormal breast and areolar orientation. This is called as waterfall or uniboob. So, we've been talking about everything about superficial fascia. Can the mammary gland ever enter deep to deep fascia? Yes. The axillary tail of Spence pierces the foramen of Langer to enter into the axilla. The problem here is that it can sometimes be mistaken for a lipoma or enlarged lymph node. So we've been talking about breast. Is the nipple areola not to be discussed? It is very much important to be discussed. So nipple is normally at variable levels. I won't talk about all this. But remember, it's pierced by 5 to 9 ductal orifices, which are usually formed by union of 15 to 20 lactiferous ducts. There's a smooth muscle disposition. Again, I'm sure you know why. And it is having a nerve supply coming from 4th intercostal nerve. Why am I mentioning this? Let's talk about it. One, retraction of the nipple is seen in cancer, but it's important to understand when. So whenever a patient comes with a somewhat retracted nipple, question is, how recent is this retraction? So that will give you a good indication of whether this is cancer related or otherwise. There have been instances of bloody discharge from the nipple. The nipple area has not got any functional breast tissue. So, if you're doing a nipple-sparing surgery, then it can be done without, it's an oncologically safe procedure because it will give a more aesthetic, normal-looking breast and there will be lesser risk to the patient because that area actually does not contain any breast tissue. However, this requires careful dissection. Breast augmentation surgery has been known to sometimes cause loss of sensations in the nipple. So that's also one it's very difficult to dissect out and preserve every nerve. However, it is said that the sensations do come back in most of the cases. Dissection, the areola, we already know enough about it. It's a darker colored area around the nipple. Important for us to remember that beneath this is the lymphatic plexus of Sappi, into which the lymph drains before lymph draining further. We will discuss this in the later part of our discussion. So now you are seeing a schematic diagram of the mammary gland. All the lymph lactiferous ducts and lobes seem to be in a radial direction. Question is, why is surgical incision done radially? Obviously because if taken radially, it will not damage too many of the lactiferous ducts. However, some authors have said that lactiferous duct does not only drain the area in its radial quadrant. It can drain more, and that thought must be kept in mind while operating on the breast tissue. Blood supply of mammary gland, important from point of view of surgery, of course. There are 3 main arteries we have to think of. Internal thoracic, axillary, intercostal. Let's take a look. So these are all arteries you are aware of. Here is the internal thoracic artery branch of first part of subclavian. Its branches pass through second, third, fourth intercostal space, form medial mammary branches, supply the mammary gland. Some of these can become very large and dilated, forming large perforators. Especially large perforator may be seen in the second intercostal. Sometimes such large perforators from fifth and sixth space also come to supply the mammary gland. On the lateral side, superior thoracic, lateral thoracic artery. The lateral thoracic artery forms the lateral mammary branches supplying the breast from lateral side. Some branches can also come from thoracoacromial and a few from posterior intercostal. But the thing to note is that there is a lot of variation in this. In 50% cases, intercostal arteries have negligible contribution. In 30% cases, axillary artery itself has negligible contribution. So most of the contributions coming from internal thoracic. In 18% cases, they have the same equal contribution to supply of mammary gland. So there is a lot of variation, and it must be, all these variations must be looked for and explored before the surgery. What about venous drainage? Do the veins correspond? Basically, venous drainage results in a circulus venosus, from where blood goes to axillary vein, internal thoracic vein. But some of it goes to posterior intercostal vein, to esophagus, to internal venous plexus, and through that to various bones of the body, clavicle, cervical vertebrae, humerus, everywhere. And this is the explanation for retrograde metastatic spread of cancer to bones. So this pathway must be known. Nerve supply is by 4th, 5th, 6th intercostals along with the related sympathetic supply. With this, we come to lymphatic drainage of mammary gland. So first I want to introduce lymph nodes, then we will talk lymphatic drainage. So what are the lymph nodes? Basically, lymph nodes are axillary group of lymph nodes. So it's an anterior axillary, posterior axillary, lateral axillary, central axillary, apical. There's also supra and infraclavicular, a medial internal mammary, and a posterior intercostal lymph nodes. All these are relevant for drainage of mammary gland. Remember the central group of lymph nodes I showed you here. Okay, the intercostobrachial nerve almost passes through them. So if they are thickened due to some reason, maybe cancer, then the patient can come with a sole complaint of pain along the medial aspect of the arm, which is supplied by the intercostobrachial nerve. Lymph nodes draining the breast drain in this manner. Anterior, posterior, lateral, drain to central, drains to apical. Apical also receives lymph from the lymph nodes, infraclavicular lymph nodes, and then it passes it upwards. So, apical group of lymph nodes are an important lymphatic barrier for upper limb and mammary gland. So, we must know how to palpate these. One hand inside the patient's axilla, other hand palpating the apical lymph nodes from the surface. What are Rotter's lymph nodes? Rotter's lymph nodes are lymph nodes between the pectoralis major and pectoralis minor, also called as interpectoral nodes. Sometimes missed during surgery, therefore they have to be mentioned here. So there is also a simpler classification of lymph nodes as level 1, 2, 3. Level 1 is below the level of pectoralis minor, 2 is behind it, and 3 is above it till the lateral border of first rib. Some people have mentioned the muscle as pectoralis major. So, understanding the breast means at some point you need to understand the axilla also, because that's where all these lymph nodes lie, most of them. So, let's understand that axilla is a pyramid-shaped structure. Okay, it's lined anteriorly by a fascia which lines pectoralis major, pectoralis minor. Okay, anteriorly. Similarly, posteriorly, it's lined by scapula covered by subscapularis, lined by fascia. So, anterior-posterior layers are done. Medially, it's actually the wall of the thorax itself. Okay, so the wall of thorax covered by serratus anterior, lined by fascia, is the medial surface. The lateral part of the axilla is actually your bicipital groove of humerus, very thin, narrow space. What about the apex and base? So the pit of your axilla, if you do that, you will feel there is a depression in your axilla. That is the base. It's free, open. And the apex is the point where all this meets together bound anteriorly by clavicle, posteriorly by upper border of scapula, and medially by the lateral border of first rib. Okay, so that is the apex. This is the axilla in which you're going to go looking for axillary lymph nodes. There's also a word used very often, sentinel lymph nodes. What's a sentinel lymph node? That lymph node in which the lymph from a primary breast tumor drains first is called as a sentinel lymph node. There can be 1 or 3 to 4 also. So such sentinel lymph nodes are found out and then they are biopsied. And if the sentinel lymph node is clear of cancer, then it is assumed that the breast cancer has not spread. Of course, there are many nuances to this. I'm giving you the basic. And if then it is found that the sentinel lymph nodes are affected, then the treatment strategies are altered according to the presence or absence of cancer cells in the sentinel lymph nodes. That's sentinel lymph node biopsy. So we've got a good idea of lymph. Now let's talk about lymphatic drainage. So lymphatic drainage can be divided into that drains the parenchyma, nipple and areola, and that which drains the overlying skin. So let's look at images. So lymph node, the lymphatic drainage of parenchyma, nipple and areola is 75% to the axillary lymph nodes, from anterior, posterior they go to central, then they go to the apical group of lymph nodes. 20% to the internal mammary lymph nodes and about 5% to the posterior intercostal lymph nodes. That's the basic drainage of mammary gland. What about overlying skin? The overlying skin again there's so much of written material. As usual, I suggest use images. So the upper part and the mammary gland can be divided into parts. Lateral part drains into axillary lymph nodes. Upper part into infra and supraclavicular lymph nodes. The medial part, interestingly, drains into internal mammary lymph nodes of same side as well as opposite side and receives lymph from the opposite side as well. Now do you understand why we asked ourselves that question in the beginning? That if you have you see a patient of one-sided cancer breast, you still examine the opposite side lymph nodes to check for breast cancer spread from one mammary gland to the other. Some of the lymph also crosses the diaphragm, entering into the abdominal cavity. They can result in thickening of the hepatic lymph nodes, causing this is very close to the bile duct, so it can cause obstructive jaundice. Some cells can be seeded into the cavity, landing on the ovary, causing formation of Krukenberg tumor. So all this comes under lymphatic drainage. So now, on the basis of all this, certain surgeries are planned, such as simple mastectomy, where there's entire breast, nipple, areola, overlying skin and lining of the chest muscles is removed. A modified radical mastectomy, when all this is removed, plus a few of the lymph nodes and a few of the chest muscles. Radical mastectomy, when all of the lymph nodes and many of the chest muscles are removed. A skin-sparing mastectomy. Now this is done where the breast, nipple, areola are removed, but the overlying skin is spared so that it can be used for reconstruction of the new breast. As we discussed earlier, there's a surgery, the nipple-sparing mastectomy. In this, now very carefully the nipple will be dissected out, removing all the breast tissue, but the original tissue can be used for reconstruction. So this is a nipple-sparing mastectomy. But when you're doing all this, there will be quite a few nerves that one would need to watch out for. The list is given here, but let's look at images. So you should watch out for long thoracic nerve, which can be found in relation to the axillary vein, quite close to the apex of the axilla, and then it runs down along the chest wall as seen here. The thoracodorsal subscapular nerves are found quite close to the subscapularis muscle at the back or along the medial border of the latissimus dorsi muscle. Medial and lateral pectoral nerves. Now, medial and lateral pectoral nerves are found in relation to pectoralis minor. Lateral is found above and medial is found below the pectoralis minor muscle. So, question is, So let's ask ourselves some questions to see if we've really understood this. I've given you a lot of information. Have we really found anything useful here? Bilateral nodes need to be examined even in unilateral carcinoma of breast. Why? Can you explain? I'm sure you know the answer to this. Next is, what is peau d'orange? So, when does the breast look like, have the appearance of an orange peel? This is seen when there is, because lymph nodes are thickened and matted, the lymph is unable to drain back. So there's a lot of edema in the skin. So the points where there are hair follicles, the edema begins to happen around it, giving that typical orange peel appearance. What is mammography? Examination of the breast between two plates for radiologically is called as mammography. It's used as a pre-cancerous screening tool. Is it possible to inherit breast cancer? I'm sure everybody knows about the BRCA1 and BRCA2, which are associated with breast cancer. So I won't even presume to talk about this. So this is a lot of discussion on the surgical anatomy of mammary gland. I really hope it helps you to perform your surgery, study your surgery subject better. As usual, all this in the form of notes, like I told you, is available on my website. You can always visit there and study this in the form of handouts. All right, I enjoyed taking this lecture. I hope you enjoyed it too, and I hope it helps you in your future studies and surgeries. Thank you. Bye.